Good morning, everyone. All right, so hello and welcome everybody to our Grand Rounds event today. Whether you're joining us here in Rango's Auditorium or somewhere else virtually, we thank you for taking time to attend this very special presentation this morning of the Howard A. Mermelstein, MD Memorial Award and Lecture. Today, we celebrate the memory of an outstanding physician, Dr. Howard Mermelstein. Dr. Mermelstein was a dedicated pediatrician, trusted friend, and compassionate caregiver who devoted his life to caring for Pittsburgh's children and their families. Dr. Mermelstein began his career at Children's as a pediatric resident in 1949. Over the course of his career, he became known as a respected mentor and published clinical investigator. Dr. Mermelstein also provided valued leadership to our medical community by serving as the past president for both the Allegheny County Medical Society and our own Children's Hospital's medical staff president from 1989 to 1990. I'd now like to turn the program over to Jan Shaw, Dr. Mermelstein's daughter, to provide some remarks on behalf of the family.
Good morning. It's really hard to believe that it's been 33 years since our husband, father, brother, and beloved friend passed away. I suspect that some of you have never heard of Howard Mermelstein before today. I would argue that we would not all be sitting here today if it weren't for the pioneering efforts of people like Howard Mermelstein, Gene Weiner, Paul Gaffney, and others. If one were to design a Mount Rushmore to represent Children's Hospital, surely one of the images would be of Dr. Howard A. Mermelstein. Dad was larger than life, standing at 6 feet 4.5 inches. Those who knew him never called him Howie. He hated that. He was beloved to this community almost from the time he was asked by Dr. McCluskey to be one of his residents in the early 1950s. He had an energy, grace, and class that were infectious. In practice, he always had a way of making patients feel like he had all the time in the world for them. Yet he did it with total efficiency. My brother-in-law, Paul Dubner, was lucky enough to practice with him, along with the late Bernie Michaels and Dick Paul, in what was previously known as the University Community for 7 years before Dad's untimely death in 1991. After a courageous battle with lung cancer. He worked full-time, intermittently using oxygen until 3 weeks before his death. He had a deep love for this institution on whose staff he served as president, as well as on numerous committees. But his love extended well beyond Children's Hospital and the patients of his practice. He was deeply committed to the well-being of the practice of medicine in general, as evidenced by his service to the Allegheny County Medical Society, of which he served as president in 1979. He was deeply committed to the Pittsburgh Jewish community, in particular, the Jewish Family and Children's Service, which is now called Jewish Family Community Service, of which he served as president and for which there was a similar award presentation every year. He was deeply committed to the city of Pittsburgh, living in Shadyside and Squirrel Hill, although he was born in Beaver County, and adoring his Steelers, but most of all was his unconditional love for family. While this lectureship and annual award presentation began in 1994, the actual endowment was not fully funded until 2007. My late mother, Bev Mermelstein, and we 3 kids, my sister Margie Dubner, my brother Bob Mermelstein, and I, as well as our aunt, Howard's late sister, Eleanor Mermelstein, decided that his name should live on forever. So we created this endowment and award presentation. Special thanks to Carol Ashby, Amy Gelsheiser, and all the staff of the Children's Hospital Foundation for providing the nuts and bolts to get this done. I hope this provides a little background for the development of the criteria for selection of honorees for the award, which this year is presented to Drs. Michael Frack and Charles Silverstein. The criteria for eligibility have been well outlined, so I don't need to reiterate them. The awardee is chosen by closed ballot distributed by either regular or electronic mail for the entire medical staff and reviewed by a small but representative subcommittee of the medical staff and I as a member of the Mermelstein family. Doctors Frack and Silverstein's practice, along with Dr. Robert Argentine of blessed memory, who won the Mermelstein Award posthumously in 2019, joined Children's Community Pediatrics as one of the founding practices of CCP. Children's Community Pediatrics, South Hills, grew tremendously over the years under their leadership. Throughout their careers, not only did they shine as pediatricians, but they were community-minded doctors, much like my father. As stated by 4 of their colleagues, quote, unquote, the trio of Doctors Frack, Silverstein, and Argentine were a tour de force in pediatrics. All 3 of them represent the best in pediatrics, medicine, community leadership, and humanity to their families, friends, coworkers, staff, patients, and patient families. To work with these men was truly an honor and a privilege. Excuse me. They were dedicated to providing the best possible care for their patients and would often work early, late, and extra to make sure every sick child was evaluated and every concerned parent question was answered. They also were great friends and developed deep respect for each other and their pediatric colleagues at Children's Hospital of Pittsburgh. They were both mentors who taught their residents so well that some of them decided to stay on in the very practice where they learned from the best. Another example of the influence of these amazing physicians is the impression many parents had of Dr. Silverstein as the Mr. Rogers of pediatrics for his calm demeanor, which is ironic because my father was on an episode of Mr. Rogers. It was a visit to the pediatrician in 1970. Patients still ask about Doctors Frack and Silverstein to this day, even though they've been retired for years, which speaks volumes as to the type of doctors and people they both are. The Mermelstein family is happy to honor Doctors Frack and Silverstein with this award. Now I'd like to call Dr. Choi to present the award to Doctors Frack and Silverstein.
Thank you. There's really not much to add that Jan had shared about our colleagues who so deserve this award. Just to reiterate that their careers really reflect the values that Dr. Mermelstein was so well known for, their commitment to teaching and the betterment of our profession. They were beloved by their patients. They have integrity that is recognized by their peers, and they are active in their communities. In addition to the information that Jan had already shared, I did want to read this one quote that was provided by one of the people who submitted their nomination. To this day, we see patients in our office who remember and ask about Dr. Silverstein and Dr. Frack. Their positive influence for these families is lifelong and crosses generations. They maintain friendships with the staff and have several staff members who have worked with the practice for over 20 years, further attesting to the excellent standards and care that Drs. Silverstein and Frack took with their practice and their colleagues. These men truly are giants in the field of pediatrics here in Pittsburgh. I'd now like to welcome Drs. Frack and Silverstein to the stage to accept their award and invite them to say a few words.
I am honored and grateful to share this award with my colleague and dear friend, Dr. Frack. Thanks again to my associates who nominated me and to the Mermelstein family for this honor. I was privileged to know the Dr. Mermelstein, who was one of my teachers and mentors when I was a young resident here at Children's Hospital. He helped me find my way to my career as a general pediatrician. I would pass on to you young doctors some advice. Try to remember that you've taken up a calling and not a job. Your reward can be sharing the lives and the memories of the families that you serve. Always remember they are trusting you with their most precious commodity, their children. Be worthy of their trust.
Next slide, please. I'd like to start by thanking my partners, Drs. Yost, Riley, Marr, and Friedlander, for nominating me. I'd like to thank the Mermelstein family and the selection committee for their lapse in judgment in selecting me. I'd also like to thank my wife for supporting me through a couple of careers. I loved being a pediatrician and was proud to be a member of this staff at one of the greatest children's hospitals in the country. Thank you very much for this award. You'll never know how much it means to me.
Thank you.
I actually remember learning from Doctors Frack and Silverstein myself at the Old Children's Hospital. They truly are incredible teachers and pediatricians. It is now my honor to introduce Dr. Mike Pitt, who is going to give our grand rounds today. He is a professor of pediatrics at the University of Minnesota, where he's the Associate Residency Program Director, Associate Chair of Faculty Development and Strategic Planning, and the Fellowship Director for Hospital Medicine. As a winner of multiple teaching awards, Dr. Pitt speaks across the country with a primary focus of improving the way that medical providers communicate with each other and their patients. He has authored over 100 peer-reviewed manuscripts and textbook chapters in leading medical journals and has developed curricula used at hundreds of universities in more than 20 countries. As an award-winning professional magician, he has performed for Fortune 500 companies all over the world and has taught over 3,500 pediatricians how to think like a magician at the bedside to improve rapport and increase diagnostic yield. He is also the co-founder and CEO of Q Rounds, a multiple award-winning software that allows families and nurses to know when to expect the doctors for rounds and gives families an opportunity to join rounds remotely if they can't be there in person. Please join me in welcoming Dr. Mike Pitt.
So much. Hi, everybody. Okay, I'm gonna have you do something for me really quick. I'm gonna have everybody stand up. If you've got food, you can put it in the chair next to you. And I want to see how far people are from their home. So I like to see where people come from. So if we're talking Pittsburgh, if you've lived here your whole life, your hands are here. If you're 5 hours away. So give me those hands for 1 second. And I'm going to do two things. This lets me get to know the audience, but it also lets me post that I got a standing ovation later. So I just wanted to grab that picture. That makes my life better on LinkedIn. Again, my name is Mike Pitt. It's pretty, oh, sorry, let me just swap that out there. It's pretty fun to be presenting at Pittsburgh. I used to wear a hat that said, there we go, duplicate. That said Pitt as a kid. So I feel like that would be somebody named Dr. Brown presenting at Brown or Harvard at Harvard. So it's an exciting moment for me to be here. Oh, and I've got this showing, guys. Here, you know what? I will just, there we go. I can move that over there for you. Here. So yeah, let's get started. If it lets me advance my slides, and we will go from there. So a lot of us talk about the art and science of medicine. We hear this phrase all the time, but we don't reflect on what that art of medicine is. That art of medicine is a performance art. Our patients expect something of us when we enter the room. We are performers from their perspective. And I like to take some time to reflect on what is the science behind that art of medicine. And I started as a performer. I did magic professionally. I've taught magic across the country. I do magic with patients all the time and leverage misdirection and use the skills magicians have used for centuries in how I approach a patient. I'm going to start today by doing a magic trick, and then I'm going to teach you how to do it. So this is going to represent a deck of cards, an invisible deck of cards. Would you, somebody that's got their hands free, would you catch those cards for me? Right there, perfect. Mix them up. And then just have somebody, you got to take them out of the box first, but that's fine. Have somebody take out a card. I'm going to have you actually think of a card. So look at that card, think of it, show it to everybody. I'll turn my back. And you know what? If I can change it to presenter view again, so you have that. That's fine. So we'll just do. There you go. Okay, you've got a card in mind. This is going to represent a different color invisible deck. Go ahead and throw your card into that deck for me from the stage. Just fling it up here. Perfect. Inside my pocket, this will represent that deck of cards. What was the card you were thinking of? I asked you to think of a card. You said you're a ventriloquist. That was amazing. I didn't even see how you did that. He didn't move his lips. Did you see that? We can use the 7 of spades, or we can use the card you were thinking of. Since you, what would you have said? 3 of hearts. Which would you like to use? It's your choice. 3 of hearts or 7 of spades. 7 of spades. Okay. Do you remember I told him to put that card when he threw it face up in the deck? Right, it's the only one that's face up. It's also the only one that came from that different color deck of cards, the blue back deck of cards. So I told you I'd teach you how that worked. That, of course, uses a principle called the popularized by Marlowe in Chicago in the 30s that uses a full deck chase stacked on face, rough and smooth, allowing me to reveal cards on the 9s. Now that I've told you how to do that, because I just used magician jargon. If you were a magician in the room, you'd be annoyed that I told you how to do that trick. I just spoke a little fast, but I used English. If you can't pick up a deck of cards and do that trick tonight, you're non-compliant, right? This is what we do to our patients all the time. We think we are explaining things, yet we use things that we didn't know when we were sitting across the exam table, and then are surprised why people aren't doing what we tell them to. That's the thesis of this talk. Osler's quote that the art of medicine, from the prevention and cure of disease, the person who translates the hieroglyphics of science into the plain language of healing is the most useful. That's what we're going to talk about today. What is jargon? We'll define it. We'll look at why we use it in the first place. We'll actually look at a classification scheme that a colleague and I published to eliminate jargon from our diets, so we can actually identify the label, essentially. So we'll look at what types of jargon exist and how to recognize it. And then we'll look at some swaps, some proven strategies of single words and sometimes sentences that we can swap out to change the way things land for our patients. Occasionally, so Minnesota, has anybody ever been to the state fair in Minnesota? So yeah, it's the second biggest, it's the biggest by attendance in the country per day, second biggest to Texas in total attendance. But we have a building at the state fair where we run research. And so we've done jargon studies for the last several years at the fair, where we'll survey hundreds of adults and say, if your doctor said X, what do you think that means? Anytime you see that picture, that's a study I'm talking about at the state fair. So I'll just keep saying at the fair when I do that. So what is jargon? Our dictionary definition gives us a few. It says a technical terminology or idiom of a specific activity or group. I love the second definition because it says obscure and often pretentious language that then has pretentious and obscure language in the rest of the definition, marked by circumlocutions and long words. And I think the point is jargon is idiom of a specific group, and it can be weaponized. Has anybody felt weaponized jargon when they're at a mechanic and they're talking about, pipes and fluids, and you just know they are trying to get money out of you and leverage the fact that you don't know what those words mean? Sadly, when we surveyed people at the fair, people think that about us too. They think that's a reason we use jargon, is to keep them in the dark. And I'll share those studies. Why do I think we use it, or why do doctors? Certainly a shortcut, right? It's easier if we have the same language. That's a big assumption, because sometimes there's confusion and I don't know what an ophthalmologist is saying. But if we have the same language, it's a shortcut. Certainly in our training, there's a lot of fake it till you make it. You're not going to go up and present somebody's tum-tum owies. You have to kind of know what you're doing, and you learn the language there. I have caught myself weaponizing jargon to look smart. And this is mostly when my family members who are non-medical are asking me questions. I find myself using jargon as kind of a hand-waving technique to sound smarter than I am. So I've caught myself, and I have caught myself using it with patients where I'm debating something and all of a sudden I find myself using jargon and aware that I might be weaponizing it. But I think the most common reason we use jargon in this room is we just forget there was a point we didn't know what those words meant. that giving us the benefit of the doubt, we're not trying to confuse our patients. We just forgot that we didn't know febrile before medical school. And that's a big part of our thesis. Yet when we asked people, first of all, at the fair, we presented them jargon doctor descriptions on audio and non-jargon versions. And we asked, why do you think doctors use words that confuse patients? And a lot of the reason they gave us the benefit of the doubt. It's doctor talk, we're unaware. Sometimes they said we're just bad communicators, period, so they don't expect much of us. But others were that to make us feel important. And people said to drive the bill up so that I'm confused, just like we said at the mechanic in that case. It's not surprising that when we asked them to choose which doctor they would prefer was theirs, overwhelmingly people preferred the non-jargon doctor, the doctor that wasn't using jargon. And they described the doctor that used jargon as too technical or condescending and causing confusion, whereas they described the non-jargon doctor as a good communicator and approachable. It's worth noting that 10% on both sides thought the jargon doctor was competent, that it did show that they knew what they were talking about, even if they didn't understand what that meant. So we coined this phrase jargon oblivion. And it was basically that there's a disconnect between our desire to be communicators who use plain language and the reality that we confuse our patients. And that's what we'll talk about. This is for every person in the room, even people who aren't clinicians, because again, we have jargon in all of our circles. So this is state your name. I overuse jargon. I confuse my patients. This isn't for somebody else. This is for all of us, myself included. We're going to drop. I actually have a satellite feed into a hospital in Seattle, and we're gonna watch just 1 minute of rounds in Seattle. Let me do it this way here. And it did. So when I did it as the let me do the way that's going to show the other people, because that's how I had tested it. So we'll try it from. See if I can minimize that. You are slow, I bet. Yeah, you're the comprehensive work did not reveal any vascular abnormality. So your doctor was negative for fetal fetus necrosis, so there's no need for anticoagulation or an ICC biopsy. Right, mixed anaerobics, not convinced of the comprehensive infection. Your BU and things reacted to the patient's had his work, which could have signaled an autoimmune disease. We're not going to amputate your leg. You get to keep your kidneys. Congratulations. You can go home today. Yeah, congratulations, whatever. So I know that when we watch that, it feels a little ridiculous, but I'm a hospitalist. I watch rounds, and with this lens on, I still see this. I see us use words that confuse patients all the time, and we see that anxiety on their face when they're just kind of nodding along and glazed over there. If you don't mind just clicking back so I can click, and I won't do the next video if that's too much trouble there. Perfect. So let's go through the 7 types of jargon. The first is the classic, what we think of when we hear the word jargon. Your jaundice, which was due to elevated bilirubin, could be caused by cholecystitis. We're waiting for the radiologist to read the abdominal ultrasound to see if you may need a cholecystectomy. These are words that we learned in medical school. So classic jargon, those terms, disease names, tests, even our own job titles. So I want to take a quick second to say, if you're defining the jargon, it's not jargon. So if you're saying you have something called chorioamnionitis, which is when the fluid around the uterus gets infected, or in the uterus gets infected, or around the fetus, that's undone the jargon. But if you're doing this every time, if you're saying febrile, which means fever, you're just doing a vocab lesson. Just use the plain language, which is what we'll talk about. But the study about people in the waiting room of an oncology clinic, only 1 in 4 people knew what a radiologist was at a breast cancer clinic, and less than half knew what an oncologist was while they were sitting in the room. We did at the state fair, we said if a dentist takes care of teeth or specializes in teeth, what does a blank take care of? And dermatologists, 94% of people knew skin. That was the most accurate. But notice 89% knew pediatrician. The most common wrong answer was a foot doctor. And do we have any nephrologists in the room? So 1 in 5 knew what a nephrologist was, and the most common wrong answer was death. We repeated this actually 2 years later, added some new fields. Again, the point being, people rarely understand what even a job title is. They certainly, even after watching Grey's Anatomy, don't know what a resident or an attending or a fellow is. So we asked them to put in order from experience. If you've got the blue squares would be the 100%. Those are the correct answers. Bold was the most common. We noticed only 12% got it right. Intern, many people thought was the most was the least experienced, because that's who brings coffee in plain language, right? That's who makes an unpaid role as opposed to actually the trained physician in the room. We also were curious about how we introduce ourselves. So we chose I said, how would you prefer your doctor introduce yourself? Hi, I'm Alex Williams. I'll be your doctor. Hi, I'm Dr. Alex Williams. I'm Dr. Williams. I'm Dr. Alex. And it's worth noticing that the one that did not have doctor was the most preferred as an adjective. They liked it as a noun, like I'm Mike Pitt. And we tested that word your, because it's a much better way than I'm the medical student. I'm the intern. Like, hey, I'm Mike Pitt. I'm your intern. I'm the doctor that will be taking care of you in the hospital. It was a powerful word for people. Including the first name was preferred by 80% of the people. We're really the only profession that kind of insists on last name still, and it is noticed by our patients. Number 2, acronyms and abbreviations. Your EKG was concerning for an MI, but before you go to the cath lab, we'll get a CBC and coags and make you NPO. NPO is a frustrating one because it's Latin. People don't know what it means in Latin, so they translate it into English word for word. So they say nothing by mouth, which is a weird way to talk. Nobody said, what are they going to have by mouth for breakfast at this lecture today? Right? That nobody thinks that way. So if you say you need to be NPO, what does NPO stand for? Nothing by mouth. Shouldn't that be NBM? It's Latin. You should do nothing by mouth. No talking, you mean. We actually had patients, when we asked this at the fair, only 75% knew what we meant when we said you are to have nothing by mouth. Not saying NPO, just nothing by mouth. They rarely understood that, with many thinking it meant they weren't allowed to talk or swallow their spit. So recognizing that the bottom line is acronyms are confusing. ASD, think about what ASD means. Who's thinking about the heart? Who's thinking about autism spectrum disorder? Right? So I didn't know that for years. I was thinking, why does this kid go to a special school for his heart? An atrial septal defect. It didn't make sense when I would read the notes. It was like 2 years ago that I knew that meant something different. So simply stating it, saying myocardial infarction, or MI, that's a myocardial infarction, doesn't undo the jargon either. So in a paper we published this year in Hospital Pediatrics on acronyms, we showed that at the state fair, ones that are used often, ED, emergency rooms long ago said, well, we're not a room, we're a department. We should be considered a department. Yet the show is ER. No patients have that framing. And we showed that 32% of people in context saying, did you go to the ED after you saw your doctor? Only 32% knew we meant emergency department or emergency room. So very rarely are acronyms understood. Okay, category 3, medical vernacular. These are TV show jargon. This is words that we all have heard, but we rarely understand before medicine. Febrile, we had 9% of adults knew what that meant in context, 0% of teenagers. The most common wrong answer for adults was fiber, how much fiber was in their diet. And for kids, it was fertility. So teenage girls thought that afebrile meant we were saying they were infertile. So I mean, it's an important distinction of how jargon could create a bunch of anxiety there. One of the studies on remission showed patients with cancer that were in remission, about 40% knew that was good news. People didn't even know what they were aiming for as the target. I think this is where it starts to get a little pretentious, where these are words that, when I say unnecessary synonyms, there is a perfectly good word that everybody understands, and we swap in medical jargon. So for example, we say upper extremity instead of arm, or we say ambulate instead of walking. We double down with Latin acronym for right eye, right? Every time I read a note, I go, OD, dextro, right? As opposed to just saying right eye, and we would all know what you meant. Erythematous is 11 letters, red is 3, right? We can strike some of these words from our language. And if your patients would say, well, what does that mean? And you could answer it with one word, you should probably not say the first word. It should just be removed from our vocabs. There was a study in a waiting room in an orthopedics clinic asking patients, is there a difference between a fracture and a break? And I remember when I read this study, I didn't know. I thought maybe there is. I don't know. But like the answer is there's not. There's no difference. 81% of people thought there was a difference, and it was a mix. Some people said, oh, thank God it's a fracture. I was worried it was a break. And some people said, oh, thank God it's a break. I was worried it was a fracture. And I was an English major. I think of this Twain quote, I never write metropolis for 7 cents because I get the same price for city. So category 4 is those pretentious, I'm choosing a expensive word when there's a cheap one on the table. My favorite category, I don't appreciate any focal tenderness in your abdomen, and the CT scan was negative. These are words we call medicalized English. These are words that have a meaning already in medicine, but have an entire, in English. Medicine has hijacked those words and given them a new meaning that is often the opposite of what everybody else in the world uses that word for. So for example, appreciate. If someone in this room said, I don't appreciate a murmur, what they're saying is, I don't hear one, but a cardiologist might, right? It's a cop-out. Like, I don't appreciate a murmur means kind of, could you double check for me? The word appreciate in English means like, I am grateful for, hey, I appreciate that you dropped breakfast by for me, right? So my wife was looking at pictures of a family vacation. She said, gosh, my mom's gained weight. And I said, oh, I don't appreciate that. Now I'm looking saying, I don't see weight gain with my eyes. And she hears, I don't appreciate that your mother's gained weight. You know, she goes, what do you mean you don't appreciate it? And I said, I just don't appreciate that she gained weight. She goes, they were in Barbados. Why would you care? This was a vacation. You know, and this was a powerful moment that realized diet. If mom said recently, I'm a hospitalist, can she eat? And I said, yes, we'll put a diet order in. And she said, you think she's fat? And I mean, of course she thought that, right? That's the way we use that word, but medically it means something different. Unremarkable. I was giving this talk. Somebody came up once and said, I was in high school and I got a CAT scan. I was 17 years old. And I read the report and it said testicles unremarkable. And he said, for all of my life until med school, I was horrified. Like, I want remarkable testicles. What does this mean? And he finally, when he goes, oh my gosh, that just means normal. And we did show at the fair, and we said, if your test results, if you read they were unremarkable, only 80% thought that was good news. 20% took that as bad news. Impressive. I was telling you yesterday, I had a dad say, would you look at this diaper rash? And I opened up, I said, you know, I'm not that impressed. And he said, with his penis? I said, oh my gosh, thank you for clarifying that. I could have lost my job. You could have gone on Yelp and ruined my life. But again, it means to us, I am worried if I see an impressive X-ray. But if your kid shows you a drawing, it means it's good, right? And the opposite. 4 out of 5 people misinterpreted that at the fair and thought they wanted an impressive chest X-ray. Occult means, when we ask people at the fair, if you read in your note you had occult bleeding, what do you think that meant? 2% of adults, 0% of teens understood that. And the most common wrong answer was that we thought they were cursed, that they had a demonic cause of their disease. So it's a powerful reminder that in the open notes era, even what we write can cause a lot of confusion. We asked, if the tumor is progressing, is that good news or bad news? Progress is good. 21% of people thought that that was good news because progress in any other capacity is good news. No place does this medical English become more obvious than negative and positive, right? In the real world, positive is good, negative is bad. In medicine, it's the opposite. Positive lymph nodes are bad, negative test results usually good. What's interesting is when we first studied this, it was 2021, and we gave the people at the fair, if your cancer screening results are negative, what does that mean? And we gave them a multiple choice. 96% got that right. When we thought possibly the reason that was different than previous studies, it was the year after COVID, and everybody knew they wanted a negative to go on a cruise or to go on vacation. So I think that did become the language. But when we added some other jargon, when we said your blood culture is negative, now there's a little confusion because I don't know what a blood culture is, so I 10% reverted back to that must be bad news in that sense. So we lost some people. Positive with with some other jargon was even more confusing. So fewer people understood that the lymph nodes are positive was considered bad news in that sense. We did do our first study of kids this year, so ages 4 to 12, and we asked them, if you were at the doctor and you heard this, if you heard somebody say, your COVID test is negative, is that good? You know, what does that mean? And you can see they got the negatives pretty right, 84% for kids age 4 to 12. But when we started to get into things like we're going to put you to sleep, only 62% knew, and kids thought that meant they were going to be killed because the context of put to sleep in their life was that their dog had died. Or that we're going to move you to the floor meant that they were going to sleep on the floor, or that they needed to get a sleeping bag, or hearing a consultant was going to come see them today when it was often we say surgery is going to come by. Kids thought that meant they had surgery that day definitively. So just realizing that even if you're not saying it to the 8-year-old, but you're saying it to the parents, that's what they're hearing, and it's really important as pediatricians. The kids thought cats were involved in CAT scans. That again, if they were told they had to, there were no beds in the hospital, that they need to sleep on the floor, and that again, they brought their lived experience of a pet dying to their personal experience when they heard put to sleep. Okay, euphemism jargon, which is actually a nice segue because put to sleep is a euphemism, you know, when we're talking about animals. This is where we are intentionally substituting in a word to soften the blow. So sometimes in medicine, we're pediatricians. So we should be able to say pee, poop, and fart. Congratulations. That's part of our job. But a lot of people are really uncomfortable with this. And so they use words that no kid would understand when we're talking about those things. We talk about, oh, there's just a spot or some schmutz on the x-ray. You know, we'll use euphemisms there. There's a study that showed that people hold on to that for years with anxiety. Oh, I had a spot. I have a spot, you know, like as opposed to taking the time to not just leave it as a euphemism. Bugs in the urine. We had 29% of people understood what that was, and people thought it meant insects. And we were commenting on their hygiene when we were trying to euphemize a urinary tract infection. No place is this done more than conversations about death. There was a study that was done at UNC, or maybe it was Wake Forest, where they were looking in care conference meetings about in the NICU and PICU, where they were talking about death. They recorded the meetings and said, how often was the D word used, death or dying? And it was 8% of the time that it was referenced, it was used. The rest of the time they used some sort of euphemism. And what was fascinating was that the doctors were half as likely to use the word death than the patients or the families themselves. So the families were actually willing to bring this word to the table. We weren't. And they often would use a pronoun. It may happen soon, or overly medicalize it, you know, asystole, or colloquialism passed on. When my dad died and they called, and I was at APPD, and they called and said, we lost your father. I thought they physically couldn't find him. And I teach this and had this slide in my life already. And I thought it was good news because he got up and was able to be lost, you know, that we'll find him, and that's better. So powerful that even we are not aware of this use. And then judgmental jargon, these are words that land as judgy, most of the time not intentionally, but if we do examine, sometimes it's because of bias that plays that way. I mentioned non-compliant. It's a pretty obnoxious way to say that your plan didn't work, you know, like, whereas a lot of times just naming, they were unable to get that prescription filled because, and I'll share some examples of what patients prefer in a moment. We never say the word deny. We don't say denies cancer, you know, but we say denies sexual activity or denies alcohol use. Like, it's a judgy posture, and it's read that way. When patients read it, there's a study that showed people go, well, I'm not denying alcohol use. I've been sober for 6 years. And they change their doctor when they read that word in notes, in a study on judgmental jargon. The very first word we're taught as doctors is get the chief complaint. Find out what that patient's complaining the most about. And so when you read a note, patient comes in complaining of headache, it's complaining, it's an emergency room department. It's not a complaint, but it's what we're taught to do. So realizing, and I'll share some examples of what patients prefer. Failure to thrive. These words sting when it's phrased that way, failed cancer treatment, et cetera. It makes them feel like a failure. And then there's some jargon that's just rude that we use that you go, oh my gosh, I can't believe people used to say Gomer for get out of my ER for somebody that was like or rock, somebody that's on the floor, or funny looking kid. If anybody has heard this used when you're suspecting a genetic syndrome, these are horrific, but they're used, and we should just own that it's time to stop using those. I mentioned in the open notes era, which is the law now that people can read their notes in real time, this matters even more because we're creating a new level of confusion or judgment. So we asked people, what would they prefer? If an infection wasn't responding to antibiotics, only 2% wanted failed outpatient treatment or did not improve or treatment was unsuccessful. The most popular was just the infection did not improve. They preferred that, felt the less judged. If we were talking about a side effect causing them to not be able to take it, nobody liked non-compliant. Some people have said, oh, you should use non-adherent. It was exactly the same degree of dislike. It was just some patient stopped taking or patient has been unable to take, because of side effects, because of whatever reason. Patient chooses not to take, they didn't like the word refuse, they just equally preferred declined or preferred to skip. And these, again, in the open notes era, are things to just think about as we write our notes. Nobody denies alcohol use, they just does not drink alcohol. We recognize that that might not be true. That's true of everything we write in a note. So we shouldn't apply a different lens to something there. And then the first two lines of every note. So chief complaint, people didn't like the word complain being in their note. Reason for visit, patient reports. Those are the things that people preferred to see. So it's a good thing to think about striking from our notes. Okay, so we've talked about why we use jargon. We've talked about 7 types of jargon. We're going to move into some simple swaps that allow us to change the way things land on patients. So I mentioned this already, the blood culture was negative. That one wasn't as understood. When we reframe this, there's 2 things. One, when we're sharing a test result, it's helpful to give an emotion word of what it means to you to help frame that for the family. So for example, if you've ever had a loved one in an operating room for surgery and they're the surgeon's walking out and you are thinking, did they survive? Did they survive? Did they survive? Right? That's what you're thinking in the moment. You're judging how quickly they open the door. You're judging if their head is down, all before they get there. And if they sit down and say, so we got them on the table and they start to talk you through everything, you're not listening. You're just saying, and. Don't bury the lead. And so if a surgeon comes up and gives a thumbs up from opening the door, that is the best feeling. And then they can say all that stuff. So giving emotion to say, hey, I was happy to see that when we got that, all of a sudden takes the anxiety out of it. Or I was a little concerned when we saw the x-ray because it gives them that framing. And then using the patient's name as the object of a sentence, as opposed to the test, and I'll show you what this means, allows you to not use the words negative or positive. It's like a Mad Lib. If I say the test showed me, by saying showed me, and I now say your name, that Sarah does not have an infection. I can't say the test result showed me that Sarah was negative. Because I say the test result showed me that Sarah, I have to now put that in context of Sarah, does not have an infection, which I was thrilled to see. That's what we were looking for, right? So it's find that way to get the emotion in there, find a way to use their name, and you're more likely to put that CAT scan showed me that Roger did not have a stroke. Or that CAT scan showed me that Roger did have a stroke, which is what we were worried about. Here's what we're thinking for next. So getting those emotion words in. We did test this, and it's not surprising that we got to 97%. If we said your blood test showed me you do not have an infection in your blood, was more understood than the blood culture was negative. So patient says, can't I just go home today? I know you want to go home today, but the reason you need to stay is that the treatment for pyelonephritis requires IV antibiotics until you defervesce, which means you become afebrile. Do you have any questions? So the 2 things here, yes, there's some jargon, but I want to highlight a couple higher level, kind of graduate level jargon things. One is the word but. I know you want to go home today, but. When we use the word but, we use it to negate the first half of a sentence. I heard what you said, but, right? We're immediately taking the power away from what they actually said. So when we say, I know you want to go home today, but, it is a shoulders down moment. If we just put periods there instead of, and we say, I know you want to go home today. The reason I think it's important to stay, it's different than I know you. If I said, I think you're doing a great job on this rotation, but one thing I want you to do differently tomorrow is, it's like, but hey, I think you're doing a great job on this rotation. Tomorrow, I thought one thing we could work on is on the notes, right? They're just two separate clauses. So taking the word but out of our vocabulary is a powerful tool in life. When you're when you're arguing with your kids, when you're, it's a powerful weapon to remove, essentially, is the word but. The other part of that is at the end, it says, do you have any questions? This is a yes, no question. We've studied it when doctors say, do you have any questions? They shake their head no up to 40% of the time. Do you have any questions? Right? We lead the witness with our body language versus what questions do you have? Or what else did you want to make sure we covered? Or what can we clarify? It's an open-ended question. It's been shown to add only 6 seconds to the exam. So this thought that it would create this Pandora's box. It's a very subtle difference. And I have a med student who recently said, oh, why don't we try what, instead of just what questions do you have, is what questions can we answer for you? And again, it's the sense that like we expect them. And often they go, almost always they go, nope, you got it. We covered it all. But you're giving them the space to think about that. Tommy has bronchiolitis, which is a lower respiratory tract infection caused by a virus, usually RSV, that can lead to focal areas of mucus plugging, which is the reason for his respiratory distress and frequent desats to the 80s. Deep suctioning may help. This is a lot of jargon, but this is pretty common on rounds, right? This is kind of, I'm going to say my spiel. I talk through the stuff that I'm hoping they remember what desats are because we talked about that. And the reality is, so often we have spiels, we have scripts, we have monologues that we go into. And it is much more likely that somebody will remember a conversation than a speech. So the trick is, how do I deal the patient in the conversation? And it's that you take your scripts and you force them into dialogue. So instead of bronchiolitis is, it's what's your understanding of bronchiolitis? Remind me what they talked about with you maybe down in the emergency room. And get them to start that conversation and fill in. If they're wrong, if they say it's a toe infection, then you say, it's one of the reasons I asked is it's something that most people have never heard of, and I wanted to make sure it was clear. So you don't worry about shaming them if they don't know the wrong answer, depending on how you reflect that back. I used to be very proud about how I could explain things without jargon to families to understand them and give them a lot of information. And it was like I had a 2-gallon jug of knowledge of bronchiolitis that cost me $286,000. And I'm going to pour it really slowly because I'm good at this. I'm not going to use jargon. But the data show people retain 10% of what we say in the room. And so even if I'm pouring that water slowly, I'm overwhelming the shot glass. And so much of what I've learned is how to assess the shot glass. They might put multiple ones on the table for you to fill out, but I have swung way away from this is so much that I have to tell you to like, what is the core thing they need to know about bronchiolitis? What is the haiku of what they need to take home that they might text their families? Because the reality is when we leave a room, patients pick, this is a phone, by the way, for the students in the room. When we leave the room, people pick up a phone and they call their family and say, the doctors were just here and they said blank. Our job is to make that conversation make sense, to empower them to have a meaningful conversation there. And so my favorite form of teach back, instead of, okay, what did we just talk about? Which is like a quiz. It's, okay, we talked about a lot. It's helpful for me to hear how you'll summarize this to dad when you get home so we can clarify, and I can clarify any parts where I wasn't clear. So I make it my fault. The teach back it's a teach back moment, but it's a role play where they're actually pretending to tell their friend what they were in the hospital for, or tell their parent what they're going to do when they take their medicine when they get home, or the parent doing it this way. So I often use that telephone way as a way to do teach back. The last one before we pause for questions. So I'm sorry, but we have some bad news. I believe your baby has trisomy 21 or Down syndrome. We'll need to run some more tests to be sure, but given his facial features, decreased tone, and other physical findings, I'm afraid to say I'm quite certain it's Down syndrome. I'm sorry. The 2 words I want to focus on in this story are sorry and bad. And it took me a long time to get here. I had been doing, of course, we were doing work on implicit bias and our stories and our lived experience and how we walk through the world impacting us as clinicians. I met a mother of a child with Down syndrome who knew I did work with communication and said, could you help me change the way doctors tell patients about Down syndrome? And we sat and had coffee, and she said, over and over again, we talked to families and they would change the way they were told. It's not bad news. And I have to tell you, when I was having coffee, I didn't believe her. This is embarrassing to say out loud. I thought, good for you. Like that's a good defense mechanism, that would be the posture that you would be having here. But in that moment, and I've confessed this to her since, I was judgmental. I was like, well, of course it's bad news. That was my place here. She started to kind of get me some ideas. The very first patient I was paged to was an admission of a child with Down syndrome. And I asked the family, would you mind telling me how you were told? And they said, oh my gosh, please don't go there. I went to they told us our life that we expected for our child would be ruined. That they could remove her ovaries so she didn't have to have a period. She was days old when they told her that. I went to Google and I found all the things that would be wrong with my child. And now that she's 14, I wish we could hack into WebMD and put all the things that would make your life better, that their siblings would never be bullies, that you would realize what's important. And ultimately, I started to look at the data here. Dr. Scott Go out of Harvard has done work. 3,500 families. These families would not change the diagnosis. They would change how they were told. And that's evidence. I was wrong in my perspective of that. And ultimately, when talking to these families, they were often told it was a funeral procession. It was broken as bad news. Nobody said the word congratulations about the birth of their child. So I met back with this mom. We started to put together a framework for how to talk about a news that's unexpected. And one is to remember you're part of this family's story forever. When you open the door for the rest of their life, their story will say, the doctor entered the room and, right? You are the star of the beginning of that story. Take that role very seriously. It's a flashbulb memory, those memories that singe in our minds, but we hold the camera. We're about to take the picture. So we should take that role seriously. Use the word congratulations around birth, like, hey, this is still something to celebrate. It's a baby that is born. And then meeting families where they are and not bringing our bias when we project, I have some bad news. Instead, just saying, I have some news which may be unexpected. It is a biasless statement, and it's a way to, many times families will go, we thought this might, oh my gosh, we have a cousin that has you don't know where people are going to come. And even if they are in that moment of grief, it's not prescribing grief to them. It's meeting them with grief and offering hope. This is Jack. This is the son of the woman I met for coffee. It's not just Down syndrome, but it's anything that's unexpected is a powerful frame to reframe our bias of breaking it as bad news when we talk to families. And so we published this paper in pediatrics. She's gone on to found an organization called Jack's Basket, which we actually presented, I think, in Pittsburgh once. And it's a basket that gets delivered to a family of a child with Down syndrome. It's a celebratory congratulations basket. It's usually delivered by a member of the community who has a child with Down syndrome. And yesterday they did their 10,000th basket. So 50, all 50 states, 7 countries. I've been on the board of it since that coffee meeting. And I want to end. I said I wasn't going to pivot to it, but it's such a powerful video. I am going to do, even though they're going to be mad at me for a second. Project it this way for this last video. I will say that there is some foul language in this video, so if that is offensive, I apologize. You can say almost anything. Yeah. I'm not fucking anything. Yeah. So cute. I want to fuck. Well, there goes your sex life. Does your designer hurt? I hope you are ready for lots of sticky flavor. Oh, I'm eating the same close to anything. The truth is, many times, it's so good. You're supposed to be celebrating. Be sorry about a baby. Be happy. Because every baby deserves a warm fucking welcome. So with that, I want to thank you for having me. I want to thank the family, the Mermelstein family for bringing me here.